Hello, everyone in the room and also online. I hope you can hear me okay. Just maybe signal if you can't. I see some familiar faces here. We're all enjoying some nice lunch. So welcome to our Collaborative Center for Climate Health and Sustainable Care seminar series. My name is Ashley Imone. I'm a faculty member here at the Dalalana School of Public Health. And as a brief introduction to our events, for those of you who might be joining us for the first time, the Collaborative Center was launched in November 2023. It's an initiative of 4 faculties: the Dalalana School of Public Health, the Temerty Faculty of Medicine, the Lawrence Bloomberg Faculty of Nursing, and the Leslie Dan Faculty of Pharmacy. The Collaborative Center's purpose is to catalyze climate and sustainability action for health and health systems through research, education, and practice and policy change. So for this particular seminar, we have the pleasure of co-hosting with the University of Toronto's Rotman School of Management. And before we get started, I'd like to just start by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron, Wendat, the Seneca, and the Mississaugas of the Credit. I recognize that this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and learn on this land. And so now I have the honor of introducing our guest speaker, Dr. Anita McGahan. Dr. McGahan is a senior research scientist at the Burns Center for Social Change at Northeastern University, where she leads the PI Squared Project on Private Innovation in the Public Interest. She's also a university professor and George E. Connell Chair in Organizations and Society at the University of Toronto's Rotman School of Management. At U of T, she is cross-appointed to the Munk School of Global Affairs and Public Policy, the Temerty Faculty of Medicine, and the Dalalana School of Public Health. And she's affiliated at the School of Cities, Massey College, and the Schwartz-Reisman Institute for Technology and Society. Dr. McGahan, thank you very much for joining us today, and I will happily turn the floor and the mic to you.
Thank you very much, and it's a pleasure to be here, and thank you to my colleagues from Rotman, Rosemary Anam, Amrita Saha, and Gabriel Cavalli, who are expert health researchers in their own right, so it's really great to have you here too. Thank you all for being here. So this work is joint work with 2 incredibly skilled and talented young scholars, Laura Dirksen, who had been here at Toronto. She's an economist. She's now in Oslo. We're hoping to get her back. And Leo Panjalupe, who is graduated from Rotman in 2022 and is now at Wharton as an assistant professor. And we're passionate about bringing health innovation into low-income settings. And Amrita and Gabriel are also writing their thesis on these topics. So really happy that you're here too. Thank you for being here. So this project is about Malawi, and it's about an intervention to introduce electronic medical records to recover lapsed patients into HIV care. And the analysis unfolds in a context in which the climate change impact is really significant and can be directly linked to the prevalence of HIV. We're going to find that there's all sorts of concerns and issues about privacy as well. You want us to do something here, Fiona?
Pictures of the people.
Sorry.
I don't know something.
Are you okay? Is that good?
It was just whether people could see. You could see the slides.
No problem. Those of you who are online, if you have a question, just please unmute and ask it. I would love to hear from you. So just to give you a sense of the climate issues in Malawi, it's very, very different from certainly my intuition when I started to work on these topics. Here, many scholars or many low-income people in Malawi are farming and doing really subsistence farming. And this is an article from earlier this year in 2024 that describes how back-to-back climate disasters left millions of Malawians in deepening need of support. This give you sense of the direct effects of the climate crisis, Cyclone Freddy in March of 2023 killed 1,200 people. It displaced 700,000 people, and more than 2 million farmers lost their crops and livestock. So 2 million farmers lost their crops in a country. Yeah, this is a total loss of crops, right? So unbelievable impact. And then El Nino in 23-24 season triggered a drought across East Africa with 16 million people that relied on rain-fed agriculture affected. And, you know, even between these specific events, we have increasingly erratic rainfall, periods of drought, 5 different cyclones, even preceding Cyclone Freddy. So the problem here is quite extensive, and it's directly linked to social determinants of health and to HIV. So one big issue is that early warnings really often fail to reach the most rural and vulnerable communities, even when they do. So even when there is electricity and there is radio signal and there is information coming to communities, even when they do, it takes money and resources to be able to act, to be able to leave, to be able to take remedial measures around protecting your assets, your farming assets. And many of these smallhold farmers also are in debt. And what will happen is that a cyclone will, even for those that survive and the crops survive, they have no reserves left after having to respond to the crisis, and their loans to pay for their fertilizer create debts that can't be repaid in their starvation. And this drives smallholders into dangerous lines of work. So there's quite a bit of research on this. We got into this setting actually through our friend James Orbinski. Many of you may know that James just returned to the University of Toronto and to the School of Public Health because we were very fortunate to attract him, in part because we were fortunate to attract him as the new principal of Massey College. And James is a dear and old friend, and he's been supporting our scholarship in Malawi by getting us into the setting and providing us with access through Baobab Help in particular here. And I've learned a lot about this phenomenon from him. This is a quote that comes from an article that's cited here. As smallholders struggle to feed themselves and their family, one woman describes how she had to sell sex. Her farm in Najah was washed away by Cyclone Freddy. She finds clients in the bars near the village. Some men demand unprotected sex and become aggressive. Rapes occur. She says, you know, I know it's risky, but finding money to eat, especially for my children, is what is important. 5 kilograms of maize costs about $3 US. Most of the time I fail to raise that money. I sleep with 3 or 4 men each day to make more. So the HIV epidemic is directly implicated by the climate impact. For men, in addition to the practices of engaging with sex workers, there's often a practice of leaving villages, looking for work in cities as truck drivers. So this is a map of Malawi, and you can, I don't know if you can see here, Lilongwe is the capital. There's a long road that goes north to south in which many resources are trucked. And you'll see smallholder men leaving the farms and going to work in distribution centers and along these trucking routes. An estimated 56% of truckers in Southern Africa are HIV positive. It's 56%. So for Malawian population, it's 9.5%. Malawi is the 9th highest HIV infection rate in the world, among countries in the world, at 9.5%. That's pretty significant, but 56% for truckers is sort of mind-bogglingly high, okay? And what's happening is that HIV is passing through and up and down this corridor. So this fellow, Charles Makomba, he's a long-distance truck driver. There's a series of great papers by our friend Aline Gatignon on North Star Alliance. I can give you the references if you're interested. And these are North Star Alliance is a group of NGOs that's committed to delivering health service throughout Africa. Here, there's many places along the border where there are long waits for custom clearance, up to 6 days. This fellow says, usually I get a girlfriend, the following day, maybe another girlfriend. It's high risk because this dangerous disease. I always use a condom because I'm aware of it, except for with my wife, I use condoms every time. But not all truck drivers are the same. Some of them are reckless. Maybe if they have the disease, they're more reckless. The trucking companies encourage us to use condoms because they're losing drivers to death, and it's hard to replace us. But there's a very different environment, is what I'm trying to say, in terms of HIV transmission than we would be familiar with here in Canada, you know, because of the geography and the poverty and the history and the impact of climate here. Okay, the HIV epidemic in Malawi, 13,000 AIDS deaths in 2009, which is 19, which is the last year of our study. The blue arrow points to that, where Malawi is on the continent. The number of AIDS deaths is down from 2004, from 70,000 to 13,000, but still 9.5% of those 20 million Malawian citizens are HIV positive. In 2019, it's the ninth, as I said, ninth most HIV prevalent country in the world. Fighting this epidemic requires keeping people on ARTs. And you're all familiar with ARTs here. In Malawi, they're universally free to patients. They prolong life by decades. They also prevent transmission, and the prescriptions are being administered usually one prescription a month, or one every 2 months here. So as you're getting started on ARTs, they want to see you every month so that they can check your CD4 count and calibrate the level of dosage. But once you stabilize on the medicine and your CD4 count is low, then maybe you'll get a prescription for every 2 months. Okay, compliance is critical, but when you first go on ARTs, as you know, it can be, you know, incredibly disruptive. You feel terrible, you're tired all the time, nauseous. It's easy to lapse from care. And in fact, 17% of people lapse from care after initial diagnosis. At this point, Malawi, though, has been very successful, and a large part of that success is due to electronic medical records. I'm going to talk about that in just a moment. 85% of Malawians with HIV are now diagnosed. That's the estimate, with 79% of the diagnosed population being on ARTs, antiretroviral therapies, okay? The rest are either post-antiretroviral with active AIDS, and they have other prescriptions, or they're lapsing or not in treatment here. Prior to the implementation of electronic medical records, there was a paper-based system for record keeping. Okay, and I'm going to show you in a minute, and I hope I have time to show you a brief video on the implementation of the system. You're going to see what this looks like. So imagine files arrayed in a cabinet there that are all, you know, worn out and weather beaten and, you know, kind of in disarray here. Patients are coming through the door. They have, the first thing that the staff has to do when you come through a door of an HIV clinic is find your record, okay? That can take an hour for somebody to become free enough to go find your record here. If somebody doesn't show up for their appointment, their record, all else equal, very rare that their record would even be pulled, much less that they would be contact traced. So somebody comes through the door, we go for it. But if somebody doesn't meet their appointment, we just move on to the next person in the line. We don't actually pull their record and try to trace them and bring them back into care. Okay, so tracing under the paper-based system was non-systematic and even non-existent here. It's different with the EMR system. So if I have an electronic medical record system and someone misses their appointment, I still go on to the next patient, but at the end of the day, the system generates a list of people who missed their appointments with their contact information, and we can follow up. And we do follow up here. So that's that's the main difference between the paper-based system and the EMR system in enabling tracing. Okay, lapses, as I mentioned, are very common. Okay, so we're going to define a lapse in our study. So this is a quantitative event study. I'm not going to provide all of the details of it because I want to leave time for discussion, although I could, if you want to see it. I have my slides with me and can tell you more about the event study, but basically it's a differences in different study. Do you have, is that familiar to you, that terminology in public health, a diffs and diffs, in which we look at the effect of implementation of the EMR system on changes in the death rate and the patients in care rate across 106 HIV clinics. Okay, we're going to compare that to tuberculosis clinics. We don't, these things are often co-located, but we're going to find an effect for HIV, but not for tuberculosis, because tuberculosis didn't get an EMR system. So we're just going to use, we're going to do a whole bunch of robustness analysis to really make sure that we can identify the change in outcomes with the implementation of the EMR system. So 20% of patients lapse immediately after initiating care on the paper system, and 17%, it's down a little bit on the EMR system. We conjecture that part of that is because if you lapse, they know people start to learn that you're going to be traced. So they're less likely to lapse because they don't want, they don't want somebody coming to your village and saying, you missed your HIV appointment, At the time that EMRs were implemented in the clinics, on average, half of the patients were lapsed. Okay, so it's a huge problem. I'm keen to answer questions, but to just give you a sense of things, there are 700 different health clinics in Malawi, only 300 of which disperse ARTs. And of the 300 that dispersed ARTs, 124 implemented electronic medical records. We analyze only 106 because if a clinic is the only clinic to implement an EMR in its year, we have collinearity between the clinic effect and the year effect, and we want to make sure we don't over attribute year effects to clinic effects, but it's robust here. EMRs only implemented in HIV clinics during this period. All clinics that we study and all clinics in Malawi at first used the paper record system. All clinics converted between 2003 and 2012. The clinics have 3,000 patients on average. ARVs were implemented several years, 6 years prior to the period under study, and were made universally available and never ran out during the period under study. So there's sort of a constancy of the availability of the medicine. From 2006, there's a test and treat policy. So what this means is if you come in to a clinic because you're pregnant or because you have broken your arm or because of, for any reason, you broke your leg, you got in a fight, you're going to be tested. And if you're HIV positive, you're going to be moved into the HIV clinic and immediately treated before you leave. Okay, women are more likely to be diagnosed than men because of this, because women are more likely to come to clinics because of pregnancy. The medicine is dispersed for a month or two at a time, and there's follow-up visit requirements, okay? During the period under study, HIV prevalence grew, but AIDS deaths went down. Here, what do I want to say? The EMR system was standardized across clinics. I'm going to show you a video in which the engineer that implemented the EMR system is going to show you his health passport. It has a barcode on it. So if you show up in the clinic, they can scan your barcode, okay? If you forgot your passport or you don't have it, we can look you up by your name or your address or your birthday. And that also allows for a lot more continuity of care in general. There was training of staff that coincided with the computer system implementation, and only clinics that had a supply of ARTs got the EMR system. Okay, our event study runs from 2007, which is the year after the test and treat policy was implemented, through 2019, with the first year of implementation in the 106 clinics between 2003 and 2012. It's a descriptive two-way fixed effects model with errors clustered by clinic applied across a subpopulation of patients. Gabriel, you use this method in one of your studies too, so you probably know more about it than anybody here, certainly than me. Our causal claims are going to be based on qualitative evidence from interviews. We now actually have more than 200 interviews. Laura, my co-author, lived in Malawi for a couple of years as this was unfolding. Just give you the reduction in death that I'm going to report momentarily was concentrated among younger patients, especially children. Okay, so what's happening here is that it's really hard for parents to deal with their child's response to the side effects of the treatment. And it usually parents and especially mothers have multiple children, and it's very, very difficult to maintain the clinic visits, especially under the paper-based system. And what can happen in a community is they can line we have an electronic medical record system. So we have, let's say you have 3 children, we can line up the appointment dates of the 3 children automatically in the EMR system. So you can come in one time and have the prescriptions refilled for all 3 of your children on the same visit. So the EMR system is working not just through tracing, but also by improving what we would call management of the clinic. Okay, so that's unobserved in our data. But what we're going to see is that we can observe the tracing. So we're going to report on the effects of tracing, but we do believe that there are many beneficial effects of these EMRs. All right, I'm just going to there's a lot of patients. Let me just say, there's a lot of patients. I'm going to keep going. The first, because I want to make sure we have time, I promised I would try to stop talking by 1 so that we could have a discussion. There's 2 research questions. Here's the first one here. Thank you. She just said I could go over 1. Okay, so here's what we're going to find. The patient outcomes that we're going to measure are patient deaths and then patient retention and care. So that's the tracing thing. It's sort of the opposite of tracing, is to retain you in care. I could tell you why we use retention and care if you're interested, but the basic reason is because we're worried about people having 2 different records that aren't linked. So if we measure the total retention in a clinic of all patients, even if you had 1 patient, so prior to the EMR, patients don't have patient numbers. The EMR is when patient numbers are implemented. So if we missed matching you with your paper record, we might have 2 patients associated with your thing, and we don't want to overstate the impact of the EMR on tracing. So what we'll do is, just by looking at total numbers of patients served, we can reduce that problem analytically. Okay. Anyway, that was a little wonky. Sorry, if that didn't make any sense, it doesn't matter. Okay. So here's our overall argument that the implementation of an electronic medical record system allows better tracing of lapsed patients, and that in turn leads to better compliance with the medicine. We find a huge effect, 34% more patients in care, okay? And more patients in care and more continuity of treatment leads to less death. 28% fewer annual deaths in the year after EMR implementation, after controlling for clinic fixed effects, year fixed effects. It's a differences in differences thing, and clustering errors by clinic. So very, very well identified. Okay, bunch of robustness checks. here. I used to work with Paul Farmer. This is years ago. Amrita, you know this story. And when I first met him, I was introduced to Partners in Health in order to implement some management systems. And Paul said to me, which patient shouldn't I treat while I do your management stuff? He's a little cheeky. He said it in a warm way, but he was expressing skepticism about management. And as you may know, and he and I have co-authored together, we've done a bunch of stuff. I had a wonderful time there. I learned so much. He died in 2023 of a heart attack while teaching in Rwanda. After teaching in Rwanda, he died in his sleep one night. And I'm so mad that I can't say to him, Paul, my management intervention saves as many people as ARTs. So of course you need the ARTs in order to be able to accomplish this result, but there's no other health innovation in Malawi that's had as great an impact on the reduction of death as this management system. Paul, wherever you are. Okay. I want to talk a little bit about privacy. The patients that benefit the most from this system are the ones that say that they didn't want to be traced. Okay. And the reason why is they're traumatized at the time of diagnosis, which is the time at which they are being asked their preference. There's also a selection bias. Clinical staff will only ask patients if they agree to be traced if they believe the person is going to say yes. Otherwise, they're just not going to say, they're not going to ask you because they don't want to hear no, right? Okay. If we take those that are not asked together with those that say no and compare them and put them together, it's 1/3, and compare that with the ones that said they want that they're okay with being traced, okay? You get even more of an impact on reduced death, okay? And the reason why really has to do with the patient's needs. You know, the same people that go to the dentist are the ones that do their annual checkups and the ones that, take care of their medical problems as they arise. The same people that are likely to be adherent to their appointment schedule are the ones that assent to being traced. The ones that are in greater duress, greater despair, greater poverty impact, greater traveling up and down the roadways, greater displacement are the ones more likely to lapse, and also the ones less likely to assent to being traced, okay? So we're finding that the impact is concentrated, not concentrated, but is greater on the small portion of, or the smaller portion of people that either don't consent or are not asked about for their consent. Let me ask for your help. I want to just spend a moment or two just showing you this video. This is the chief designer of the project. Can you put that up closer? Yeah.
Sorry to interrupt, but I can't hear the TED Talk.
Oh. This is someone on the Zoom call who can't hear. And I think the reason why is because you have to click a certain setting when you share.
Enable the audio.
That enables share sound.
Oh,
See it there?
perfect.
Okay,
Well, we're gonna try that again. Thank you to whoever told us that.
let's try it again.
We have long and
Can you hear
frequent
now?
power outages,
Yes, thank you so much.
low penetration of
Thank
computers, slow internet connections, and a lot of patients visiting understaffed hospitals. Since the HIV epidemic, hospitals have been struggling to manage regular HIV treatment records for increasing volumes of patients. For such environments, importing technology systems developed elsewhere has not worked. But in 2006, I joined Baobab Health, a team that uses locally based engineers to develop suitable interventions that are addressing healthcare challenges in Malawi. We designed an electronic health record system that is used by healthcare workers while seeing patients. And in the process, we realized that we not only had to design the software, we had to implement the infrastructure as well. We don't have enough medical staff to comprehensively examine every patient, so we embedded clinical guidelines within the software to guide nurses and clerks who assist with handling some of the workload. Everyone has a birthday, but not everyone knows their birthday. So we wrote algorithms to handle estimated birth dates as complete dates. How do we follow up patients living in slums with no street and house numbers? We used landmarks to approximate their physical addresses. Malawi had no IDs to uniquely identify patients. So we had to implement unique patient IDs to link patient records across clinics. The IDs are printed as barcodes on labels that are stuck on personal health booklets kept by each patient. With this barcoded ID, a simple scan with a barcode reader quickly pulls up the patient's records. No need to rewrite their personal details on paper registers at every visit. And suddenly, queues became shorter. This meant patients, typically mothers with little children on their backs, had to spend less time waiting to be assisted. And if they lose their booklets, their records can still be pulled by searching with their names. Now, the way we pronounce and spell names varies tremendously. We freely mix R's and L's, English and vernacular versions of the names. Even Soundex, a standard method for grouping words by how similar they sound, was not good enough. So we had to modify it to help us link and match existing records. Before the iPhone, software engineers developed for personal computers. But from our experience, we knew our power system is not reliable enough for personal computers. So we repurposed touchscreen point-of-sale terminals that are meant for retail shops to become clinical workstations. At the time, we imported internet appliances called eye-openers that were manufactured during the dot-com era by a failed US company. We modified their screens to add touch sensors and their power system to run from rechargeable batteries. When we started, we didn't find a reliable network to transmit data, especially from rural hospitals. So we built our own towers, created a wireless network, and linked clinics in Lilongwe, Malawi's capital. With a team of engineers working within a hospital campus, we observed healthcare workers use the system and iteratively built an information system that is now managing HIV records in all major public hospitals in Malawi. These are hospitals serving over 2,000 HIV patients each clinic. Now, healthcare workers who used to spend days to tally and prepare quarterly reports are producing the same reports within minutes. And healthcare experts from all over the world are now coming to Malawi to learn how we did it. It is inspiring and fun to follow technology trends across the globe, but to make them work in low-resourced environments like public hospitals in sub-Saharan Africa, we have had to become jacks of all trade and build whole systems, including their infrastructure, from the ground up.
That's it.
Thank you.
So you can stop sharing altogether if that's okay. Thank
Yeah.
you. Thank you for handling all this.
No problem.
Okay, so
That's great.
Okay.
the problem, of course, is that climate change is not addressed by an electronic medical record. Okay. There's, if you think of, I mean, this is, I need to wait till you finish because it's hard to concentrate until you're done.
Sorry, I'm
No,
trying
no.
to figure out how to,
Here,
whoops.
if you just close, if you just close here,
Now we've got Oh, no, tech problem, sorry.
No, it's not.
Okay.
We're good. If
Oh,
you did,
phew,
pardon me,
maybe.
if you just close this here. And then we go here. We can see.
No.
There we go.
Okay, perfect.
So if you have any questions online and you want to unmute and ask them, please don't hesitate. I just wanted to conclude by saying that, and thank you so much for this, that, you know, the 1/3 of people that are not consenting to be traced are those that are more likely to be in despair. The more that people get displaced by cyclones and, you know, these adverse climate impact events, the more the men are engaging in trucking and trucking related activities and, you know, driving HIV up and down the highway, the more that sex work and you know, it becomes prevalent because of these desperate situations, the less EMRs are going to work to remediate those challenges, right? Because the desperation itself is not just increasing the HIV burden in the country, but it's also making it harder for people to be able to go to clinics and to stay, you know, compliant with their medicines. Stability is critical, not just to get people even to be diagnosed, but also to not lapse from care and to be able to tolerate the medicines in the first place. So as impressive as this might be to someone like Paul Farmer, I can still hear Paul Farmer in the back of my mind saying, but what about the cyclones? So thank you for your kind attention.
So, Fiona Miller here. I'm going to help sort of host the rest of this conversation, and please put your hand up for questions or any questions in the audience. I certainly have some, but you can go ahead and get it started.
Yeah, thank you so much for sharing this fantastic.
My honor.
Thank you. I'm glad this was decided your beach third year, and I'm from Nigeria, so I worked in rural Nigeria, so I totally relate with, and that's what brought me here to listen to how you implemented EMR. And one thing that I was thinking about the challenges in our setting, which is power supply and internet connectivity, and technical skills of healthcare workers. I think the YouTube video touched a bit on how they address the
two of those
connectivity, right? And by building their own structure in Lilongwe. So I was wondering how you overcame power supply. And I think during your lecture, you talked about training of healthcare workers, but still that piece on power supply is
power supply, yeah. So just to be clear here, and pardon me, I didn't quite hear your name.
Gladys.
Gladys. Thank you, Gladys. We didn't implement this. Okay. This fellow named Jerry Johnson, and I think his name was Mwambe. I forget his name, full name, but he had an anglicized name, and he's native of Malawi, Jerry Johnson. He is an engineer, and he and his friends really created Baobab Health, which, by the way, was supported by Dignitas, which was James's organization. And what they did was they got lithium-ion batteries in a stack, and those cell towers were not in Lilongwe, they were at the rural clinics. Lilongwe has like Lagos has the outbound signal. It's just that in the rural settings, there's no way to connect to it through landlines. So they built those towers in the rural clinics and associated them with, there's enough electricity and enough solar energy for them to keep those lithium-ion batteries recharged. They got a number of grants to do this. They were super entrepreneurial in terms of appealing to business people that wanted to create rural health clinics that worked. And that's the story. Baobab Health, it was the hero here.
Great,
Yeah, and Jerry Johnson.
great, thank you so
Yeah.
much.
You.
My last piece is during your slides, there was a place where you said these are still in place to date. Are these still functioning? These 109 clinics, are they across, like, is there rural, urban?
Yeah, they're mostly rural
Great.
and they're all still functioning today. Yes, I think antiretrovirals are now available in more than 124 clinics now. And the EMR system continues to roll out, but we stopped in 2019 because of the pandemic. Yeah.
Thank you very much.
Wonderful. We have two more questions. We have two questions online and then I'll come to you. So Kate first and then Imani. Kate.
Hi there. I'm actually a doctor from South Africa. I'm currently in Toronto, but and I've done a lot of work in HIV in urban and rural settings as well. And in South Africa, we do have some sort of electronic records. We don't use them as the clinicians, but they the data clerks sort of record the patient visits after the visit. So we have some sort of tracking of when patients come. But what I wanted to ask, I might have missed it, is are the clinics linked? So if a patient attends one clinic, but then say travels to a different part of the country, are they able to then access the records? Because that's what we don't have in South Africa. We struggle because we have patients traveling all over and then we lose them and they come back and in between they can't go to clinics. Okay.
Yes, they are. We have evidence that only about 6% of patients actually ever go to a different clinic. Only about 6%, but yes, they can be traced. Their records are harmonized across the country. So they're being stored in Lilongwe electronically on the cloud. They're being stored in Lilongwe. That's why this connectivity is so important. It's one reason the connectivity is so important. So that someone, even if someone just shows up with their pill bottle and needs more pills, they can be linked.
So Imani.
Okay.
Oh,
Thank
sorry.
you.
Thanks, Kate.
Thank you. Hi, everyone. Thank you, Madeline, for such a great presentation. I'm a second-year Black Health student at Dalilana, and I also work within HIV research. And some of the things that I'm learning, particularly in the African context and African policy context, is Malawi does not promote routine CD4 monitoring within their larger legislation. And I was wondering if CD4 monitoring was incorporated within the EMR system.
Yes.
Oh, it is? Okay, perfect.
So there's a minister of health in Malawi that is extremely committed to innovation in HIV care, that is pushing for implementation of important practices like monitoring CD4 count, even despite not having a legislative mandate to do that. So it's super interesting to see how that has unfolded. He's got a huge amount of support in the populace. And there's a lot of politics in that, in the way that that's unfolded, because the president of the country doesn't. I'm trying to figure out a way to put this politically correctly. Wouldn't have prioritized the same things, and seems to me to be surprised at how important and popular these things are, like monitoring CD4 counts.
Right. No, that's really wonderful to hear. Thank you.
Yeah.
Great. And here.
Hi, my name is Erica. I'm specializing in health law and policy. I had a quick question. I was not able to understand. So correct me if the numbers that I'm citing are wrong, but the slide said that there are 80% of the people with HIV have been diagnosed and 79% are on antiretrovirals already. What is the reason between for the disparity between these numbers and the access to treatment by truckers and sex workers? Is there any reason for that disparity? And
So there's 85% of people have been diagnosed. So
okay,
one disparity is what's happening with the other 15%. So those are newly infected people, or there's quite a few children that are undiagnosed relative to their numbers. So children are disproportionately undiagnosed, but children are still relatively less likely to have HIV than the adult population. And then there's adults that are undiagnosed, right? So that's one difference between those that are diagnosed and the 79% that are on antiretrovirals. The other 21% are either, they're not prescribed antiretrovirals. They may be prescribed some other medicines. Okay, many of them have advanced AIDS for which antiretrovirals are no longer tolerable because antiretrovirals are pretty hard on you. Or they have other infirmities that would make them vulnerable, like heart conditions or cancer or some other physical, some other illness that would interact with their ability to take antiretrovirals.
And what makes the truckers and sex workers a special community that's not able to access these treatments?
They can access these treatments. It's just that the passing of HIV between individuals is amplified by the sex work and the truckers, okay? And I would also say that because of climate crisis, many people that are displaced from their farms or lose access to their livelihoods because of, bye-bye now, Gladys, because of the impact of climate on them, don't prioritize. They seem not to prioritize compliance with their HIV protocols as they seek to survive a climate event.
Okay, yeah, thank you.
Hi, my name is Yu Chen. I'm currently a first year Rotman MBA student.
So how fun for you to be here. Amazing.
Yeah, before joining Rotman, I was working with an international organization based in Zambia, and I was there for 2 years. Also working in Zimbabwe for a project for HIV rural testing in community. So I'm very interested, it's very inspiring to see all the impact from the management of EMS system. I also want to ask more about, have you faced any interoperability across different systems in the country? Because from what I have understand, at least that in Zimbabwe, when I was working we realized that in the clinics, they have their own electronic system or paper-based system. And then that need to be linked to the lab because after HIV is diagnosed, they need to do viral testing every 6 months or every year. And those data is hard to pull and linked. Have you faced any challenges of that and how the research has tackled it?
I mean, again, just to reiterate, it's Baobab that did all this work, not us.
Okay.
Just studying, this is like a sort of, you could think of it as an evaluation or an evaluation study if you wanted. But what Baobab did is at EMR implementation, the paper records for the year prior for each patient were entered into the EMR. So I don't know if you picked this up. I can't remember if the portion of the clip that I showed is one in which Jerry Johnson said this, but he said, what he said was previous systems had not been successful. Previous implementations of systems had not been successful. So he went in and the Baobab team went in and said, there has to be a harmonized central storage system in Lilongwe, which is what Kate was asking me about too. I don't know if she's still here.
Yes, I'm here.
They don't have that in South Africa, if I heard you correctly. So they didn't have it in Malawi previously with these different attempts to implement. All these different attempts were in Lilongwe, in the capital city, in the big hospital, and it just failed, right? So they knew had a design principle that they needed to have one harmonized system. And they also had as a design principle that they had to get patients 1 year of records, 1 year of clinical data from the paper system. And they did that even for patients that had lapsed. So all persons, all paper records were translated into the EMR system prior to the activation of the EMR system in a particular clinic. It was staggered over time. I should also add that they also created an electronic record of deaths. Okay, so if patients had died prior to the implementation of the EMR, they also recorded those. And that's what allows us to do the diffs and diffs.
Right, because you can see.
Because you can see
How many died.
how many died under the paper system.
So can I ask a question? Can I
Yes.
jump in and put myself in here? As a scholar of business innovation in the public interest, could you comment on the innovation model that was used here that sounds like local, mission-driven? So this isn't just a EMR that's
Toronto.
transit. Yeah.
Right.
It required local innovation, and it sounds like it required a pretty mission-oriented model of innovative development. Could you comment? It's a bit unfair to put you on the spot when, as you say, you evaluated that, but what are your reflections on the model of business entrepreneurialism that this represents, and how do we catalyze that?
So Baobab is an NGO.
It's an NGO. Okay.
Yeah, it's a non.
That's what we need. Nonprofit innovation.
I do want to emphasize that the engineers from Baobab were super savvy about electronic medical record systems that had previously been offered and partly implemented and failed. They had studied, so it's, I would say, Fiona, global, local, like it's awareness of the local needs, but it's also connected to an awareness of what international technology can offer and a series of international relationships. So for example, I don't know if you picked this up, but or if you said it, but they got the interface was donated by a failed internet startup company, and the batteries were donated. So those international connections are important. Also, just wanted to mention that Amrita is studying this global local tension in her dissertation, looking at the way that Trinidadian cocoa farmers responded to international pressure to make a transition to fine chocolate that wasn't part of local farming practice previously, and how deep that global local tension was. And you find that many of these farmers were super smart about resisting international practices that were not to their local benefit. Is that fair?
Yeah, I think that's a fair
Yeah.
presentation of the paper.
Yeah.
The implications, yeah.
Yeah, and Gabrielle and I have a paper that's part of a series that we're doing with some other scholars on how local science and local scientific knowledge is being exported from these countries once they become harmonized in global systems and get access to international opportunities. So we're finding way more synthesis between local and global scientists in a super smart way that allows both local science to develop and even some international development of drugs for neglected diseases as a result of these collaborations. And that's part of his dissertation that's going to be finalized soon. So I'm really happy you're here. Thank you both for coming.
And there was a question over there. Did you have a question?
Yeah, it's actually in line with your question. I was thinking about the technology adoption part of this.
Yeah.
I mean, having worked within a hospital system, very different one than this one, even small changes to an EMR system are massively contested by healthcare workers. And over here, we're seeing this massive, just complete change from, a paper-based system to an EMR. So like, I was just wondering, did they have to work with healthcare workers? Did they have to rehire a new cadre of the healthcare workers? Like, how does this work, the implementation of this so successfully?
They did it all through training of established healthcare workers. And it started in clinics that were relatively close to Lilongwe, you know, sort of in the outskirts of Lilongwe. And then by the time you start getting these results with the decreased deaths and, you know, more children, a dramatic reduction in child death, you get now clinic workers being mad that they haven't yet gotten access to it. So you sort of,
It pulled them on.
yeah, you sort of start to create this momentum. And there's more stuff online that describes how the clinical workers responded.
And
Not like Paul Farmer.
Baobab Health, really quick, sorry, Baobab Health was the one that made this happen.
So
The health.
Baobab Health now
Okay.
does the training as well as the implementation as of my last check-in with them. Dignitas was doing the training before it before it shut down. But a lot of the people that had been at Dignitas now actually work for Baobab Health because Dignitas had the end of its USAID grants, And, you know, this reflects another phenomenon which we share in management and public health, which is that the training of workers and the capacity building in workers way outlives the organizations at which they're employed. So people are trained in a particular way. They can take those skills and the capacity that they have to another employer and still deploy it in the setting. And I think we might be out of time.
We got Rosemary, did you have, and Brianna, we have these two questions.
Go ahead with Brianna.
Brianna.
Thanks so much. This was a great presentation. I was just curious. So I feel like I'm working in studies of providing kind of humanized and compassionate healthcare to patients. And there's this ongoing kind of tension about whether implementing more electronic medical records or implementing more technology, kind of whether that creates a divide between providers and patients, or whether that kind of opens up and frees space for providing more humanized and compassionate healthcare. It kind of seems like your study is an argument of the latter. Anyway, I just was wondering if you have any reflections on that as far as like how these implementation of the electronic medical records has changed the way that providers can interact with their patients.
We didn't study that directly, but one thing that we have interview evidence of that is reported in the paper or in one of its appendices, because, you know, is that it became much easier for patients to go to clinic because the administrative tasks that were needed were way reduced. So like you don't have to sit there for an hour with crying babies, you know, that your children that are sick, that don't want to come to the clinic because they know they're going to get medicines that are hard to take. You don't have to sit there. You can go in and get through the process relatively quicker. So I would say we believe that it could go either way, that, you know, an implementation of a technology solution like this could either improve or detract from compassionate care. But in this setting, the reduced administrative time would certainly enhance the amount of time that was in direct caregiver to patient contact as a proportion of the total visit. That's the only thing that we would have studied here. And final question.
I was just curious about, you touched on a couple of things, Anita, in your talk about the cultural dynamics or sort of
Yes.
the setting in which these people are living. And your example about, you know, not wanting somebody to come into the village to say, hey, why haven't you come for your appointment?
Right.
As a motivator to go. And I was just wondering, you know, that area of investigation I find really fascinating because
Yes.
there are these dynamics and some stigma with HIV.
Right.
And this group that haven't accessed care, the sex workers and the truckers, you know, how, you know, in your interviews, were there some other thoughts about how to recognize and then maybe work with those cultural dynamics for those vulnerable groups?
There's certainly evidence in our interview notes of people believing that HIV is a punishment from God, that people who are bad people get HIV. And we do see a dissemination of more knowledge about disease transmission over time in the interview notes. And yeah, it's not the direct subject of what we study in this paper, but yeah, I mean, there's evidence of that. I also just briefly just want to clarify, many of the sex workers were actually on antiretrovirals, but then as they traveled and as they escaped their communities, they stopped, they lapsed.
Right.
Because, you know, your village is decimated by a cyclone and you just have to leave, you know, and then you're living
Gotta survive.
you're living on the streets in Lilongwe and you're not going to the clinic anymore.
Well, on that note, I'll have to thank you so much.
Thank you.
Anne, for this terrific talk.
I don't
I'm Rosemary.
Really nice to meet you.
I'm Rita.
Yeah, I mean, strategy.
You're in strategy. Okay, Gabrielle, we know each other.
We know each
I used to be on this other